So good morning, councillors, ladies and gentlemen. It is now 10 o'clock on the nail. It is Monday the 11th of April 2022. Welcome to the County Council Chamber for this meeting of Staffordshire's Health and Care Overview and Scrutiny Committee. I am your Chair, Councillor Jeremy Pert. May I remind committee that today's meeting is being recorded, and for those who want to watch today's session back, the recording can be found on the County Council's website. The meeting is also being beamed live for people to be involved and will cut off 20 seconds after the equipment has stopped. All voting committee members are in the chamber in person, and there is a variety of people. I'm not going to yet, so I'm hopeful there will be a variety of people online as well. So can I thank our guests for their input and the papers so far and their time. Can I just remind committee that the aim of these sessions is for councillors and committee to secure both assurance in what is being done and that it is appropriate for all residents of Staffordshire, and secondly that we are looking far enough into the future to meet the needs of our residents' health going forwards, bearing in mind the supertanker that is the NHS. One of the regular discussions that the chairs have with the leader and the cabinet members of the council relates to risk. So we need to make sure that we have delved deeply enough to ensure that we understand the risk to our residents based on health. So this morning, can I ask that our presenters restrict their opening comments to 10 minutes, please? We're on a tight timescale, and I want to make sure we use every minute available for scrutiny. And second of all, can we focus today on tangible outcomes for the residents of Staffordshire? So that brings me to this morning's agenda. First of all, apologies. Now, I know we have apologies from Councillor Martin Buttery and Cabinet Member Julia Jessel. Do we have any other apologies?
Yes, Chairman. Apologies from Councillors Rosie Claymore, David Latham, Ian Wilkes, Phil Atkins. Julie Cooper is in attendance this morning as a substitute for Councillor Wilkes, Chair.
Thank you, appreciate that. So item number 2, declarations of interest. Do we have any declarations of interest relevant to this morning's agenda? Councillor Anne Edgeler. Thank you. Item 3. Minutes to approve the minutes of Tuesday the 15th of March 2022. Can I ask if the minutes are a true record of our last meeting on Tuesday the 15th of March? For those of you who were there, were they a true and accurate record? I've got a proposal, I've got a seconder. Thank you. Are we all in agreement? That looks unanimous, thank you. I'm reliably informed that all actions have been followed up and all information received to date has been circulated. The next item covers the Cannock MIU. We'll come on to that in a minute. And just for information, letters have been sent to DEFRA and a joint letter to the Prime Minister is being worked up so that it will go between the Chair and the leader of this council. Anne Edgeler.
Thank you very much, Chairman. I just want to comment, actually. It's the first time that I was in Newcastle and I actually went to where there was...
Does this relate to the minutes, the accuracy of the minutes? Or the follow-up?
It relates to what's in the minutes, actually.
But effectively, we're only just approving the minutes.
Okay,
we're not
fine.
really having a debate about the minutes. Otherwise, we'll get caught in a rabbit hole. I'm sure in your inimitable style, Anne, you will be able to weave it into the agenda somewhere else, because you usually do. And so I will leave that challenge with you, and I will try not to interrupt you next time. Right, okay, so I think we've covered the letters. So can I move on to item number 4? Where I could have done with Marcus. Tracy.
I've tried to contact him to dial in at 10:05, but Chair, if you want, I can give you the update if that would be helpful.
That would be extremely helpful. So before we take this item, good morning, Tracy Shew, and thank you for coming in person. Really nice to see you and that you actually do exist outside of a screen, so not that I didn't believe that. Can I just say, before we take this item, that this is an update And I think we need to be very mindful that we are now in the season of purdah. So I would not want to use this session as a breach of purdah. So this is meant to be a verbal update, not a scrutiny of the verbal update. So over to you, Tracy.
Okay, thank you, Chair. And I'm Tracy Shewan, Director of Communications and Corporate Services for the 6 clinical commissioning groups and the integrated care system. The update for Cannock MIU is that we are looking, as Marcus said before, at getting a step-in provider to provide the services for the people of Cannock, and we're still on track for that for June, 1st of June, as we said before.
Thank you, that was very succinct. I think in broad terms what you're saying is that the commitments made at the last meeting are still very much in line, and that is what you as a CCG and ICS are working towards.
Correct, thank you, Chair.
Thank you. So let me move on to item number 5, care home update. I think we're going to have to move forward to item number 6 because we don't have Richard Harling with us. This is the end of term blues, I fear. So, can I move on to item number 6, Chris Bird? Chris, good morning.
Good morning, Chair. Hopefully I have appeared on your screen and you can see me and hear me okay.
You're with us and we can hear you. Thank you.
Thank you, Chair. So I've been invited this morning to provide an update on the work that the NHS is taking to address the challenge of climate change. We've shared a report and a short slide deck, which hopefully colleagues will have in the papers that are available to them. I am going to talk to those slides. Chair, I heard your request earlier to keep opening remarks to 10 minutes, so I shall absolutely do that. Is it helpful if I share my screen with the slides on, or do colleagues have access to them in the room?
I think sharing the slides would be good.
Okay, I shall endeavour to do that, so just bear with me 1 second.
We have them, you just might want to put them on full screen.
They're there, the Chair.
Yes.
Thank you. So these are the slides that are in the pack, and hopefully colleagues will have had an opportunity to read them. As I say, mindful of your instruction to keep to time, Chair. So NHS approach to climate change. We are describing an approach. We are ambitious, but we are behind other partners in some respects, and we have got some work to do to recover some ground. It is the slides are NHS focused, but I just want to be really, really clear from an NHS perspective. It will require us to work with all partners across Staffordshire and Stoke-on-Trent to be able to work together to achieve these ambitions. The first opening slides really just set the scene. So being clear that climate change does pose a major threat to our health and to our planet. 9 out of the 10 hottest years on record have been in the last decade. And we know that the increasing frequency and intensity of weather-related events do cause harm, whether that's weather-related deaths through heat or cold, whether it's generally warmer weather creating better conditions for the spread of disease, or the physical and mental health impact of events such as flooding. The NHS has 2 particular targets that we need to work towards, which you can see at the bottom of the slide there. So for the emissions we control directly to be net zero by 2040, and for the emissions we can influence to be net zero by 2045. And they are both in support of the UK government's national commitment to reach net zero by 2050. As I say, the first couple of slides are just scene setters. So this one provides more detail on the carbon footprint of the NHS. The green quadrant that's entitled NHS carbon footprint represents those emissions that we can control directly. So they're within scope of the 2040 timeline. The other 3/4, and particularly the blue segment, is where we need to work with partners in our supply chain around medicines and medical equipment, etc. And they're within the scope of the 2045 commitment. The other way of looking at the NHS carbon footprint is by carbon generation by sector. So perhaps unsurprisingly, colleagues will see that acute hospitals are the biggest single contributor, in some cases then followed by primary care, by which predominantly we mean general practice in that. Now, that's a bit of a challenge because primary care doesn't necessarily see itself as a sector in the same way that acute and mental health community does. It's general practice, as I'm sure colleagues will be aware, is individual practices with their own business models, essentially. So we need to be working across all of those general GP practices to address things like medicines and chemicals, the procurement, the supply, the storage, the prescription of those, if we're going to make a real impact on carbon generation going forward. Each NHS trust has been required to publish its own green plan in the January of this year, so a couple of months ago now, as well as work with partners in the integrated care system. So that would include the County Council, as well as the City Council of Stoke-on-Trent and other partners in the voluntary community sector service to produce what's called an ICS green plan. We needed to do that by the end of March. We have done that, although it's not in the public arena just at the moment because of the issues related to PERDA, as you were alluding to earlier as well, Chair. But we have formed a working group that's got representation from all of those colleagues on to bring forward ideas around the issues you see in the bottom left-hand corner there. So workforce and leadership through to adaptation, which is also known as emergency preparedness, resilience and response, also known as business continuity, essentially. We are aware that there is a Staffordshire Sustainability Board that's been established recently, and I'm in conversation with colleagues at the County Council about how we might bring the NHS voice into that. You talked at the start, Chair, about some tangible outcomes, if we can focus on those. So this begins to take us into that arena. So these are the areas that we will focus on, particularly from an NHS perspective. As I say, some of them we will be working very closely with colleagues in local authority, voluntary sector as well. So just general awareness raising and training via carbon literacy. So there are some national NHS programmes that have been brought forward that we're able to tap into. Promotion of active travel options, whether that's public transport, whether it's car sharing, the use of ultra low or zero emitting vehicles, both for NHS fleet. And as you can imagine, NHS is quite a heavy user of fleet vehicles. But we also have some lease cars that are available to staff on particular arrangements, and we need to transition all of those vehicles onto ULEV or ZEV over time. There's then the next few really are very specific to the NHS, so reducing usage of a gas called desflurane, which is used in surgery, reducing pressured meter dose inhalers. So colleagues, I'm sure, will be familiar with kind of the blue and the brown aspirin inhalers, so that they would come under scope of that, for example, and reducing medicines waste, whether that's overprescribing or unused medicines, say, for example. Net zero supplier roadmap, so working with our partners in April 2022, so just a week or so ago, all procurement in the NHS will now need to include a 10% weighting for social value, and within that, prospective suppliers will need to demonstrate to the NHS that they are able to share our ambitions around being carbon neutral, and that increases in April 2023 to any contract awarded over a value of 5 million for the supplier to be able to publish a carbon reduction plan, and that increases further in April 2024 to be any contract of any value. And then we also have some particular examples around the NHS as a plastics pledge, so trying to reduce the use of single-use plastics, which you can imagine is a challenge in the current context of the pandemic when we've been increasing use of PPE. And adopting sustainable models of care, which includes digital transformation, but mindful within there that there is a cohort of patients who will want face-to-face meetings, and in some cases will need face-to-face meetings depending on severity of risk or condition. And we also need to be mindful of issues such as digital literacy. So again, opportunities to work with colleagues in local authorities on some of those issues. Timelines that we're working to. So as I say, we've just published our green plan, although we've not gone public with it due to PERDA. We are planning a launch event in May, and we will ensure that colleagues from local authorities are included within that launch event. And then just to close, we've included a case study. So this is an example of partnership working across the NHS, the voluntary community sector, local industry and communities. So the roof at Royal Stoke and County Hospital has been equipped with solar panels, and you can see there in the picture. That generates a return to the hospital, which they're in turn able to invest in funding a local charity called Beat the Cold. And then some of the referrals into that charity come from UHM clinicians, predominantly in the respiratory clinics, where people are presenting with issues that are in part linked to their home environment. So it's quite a strong kind of virtuous circle in that respect. The solar panels are provided, installed and maintained by a local company in South Staffordshire. So again, another opportunity to just connect with local industry. I think I've stuck to 10 minutes. I hope that's helpful. More than happy to take questions and comments, Chair.
Thank you, Chris. So first of all, Anne Edgeler, then Charlotte Atkins, and then Jill Hood. Anne.
Thank you very much, and thank you for that presentation. My question really, and please forgive me if I've missed this, but my understanding is they're going to build 40 new net zero hospitals. Have we any knowledge of any of those being built in Staffordshire, please? And it's really good news about what's happening with the climate change in the hospitals. Thank you.
Thank you. So I don't know about any new hospital buildings in Staffordshire. So I'm afraid I'll have to take that one away and come back to you. What I do know is that each of the national 40 hospitals will all be built in accordance with some newly published estates guidance, which will ensure that new build hospital is net zero or equipped to contribute towards the net zero agenda going forward. I don't know specifically about whether any of the new hospitals are in Staffordshire. I'm sorry.
Thank you for your answer, but I did read that in the report. It's in part of the report. I clicked onto it in this documentation, and it's in there about the 40 hospitals. Thank you.
Chris, could I just come in and just ask a supplementary? Obviously, within the NHS estate, we can easily focus in on the big places, but bearing in mind the amount of carbon that's generated through buildings, is the guidelines that you've just described about the new estates guidance going to apply to primary care as well as acute?
It's all new NHS buildings, whether they're general practice, community buildings, community clinics or hospitals. So the NHS estates guidance applies to all new NHS build.
Thank you for that clarification. And what about retrofit? Is there a retrofit target to that?
There is a retrofit scheme that will be brought forward. So working with colleagues in the estates function across the NHS, we are in the process of establishing the baseline. Some buildings are going to provide more of a challenge than others, but we need to understand the baseline, and then we'll be able to bring forward a period of a programme of works. Some of that will also be about how we optimise use of estate. So a question about whether we need the estate we've currently got, and if what options we might have. And for the estate that we want to continue to use going forward, how do we address some of the issues within that estate around things like energy efficiency, for example.
Thank you. Really useful. Charlotte Atkins.
Thank you. Could you say a bit about the adoption of the anchor institution type approach, which involves obviously the community? You skipped over that in the presentation.
I did, Councillor. Yes, just in the interest of time, I was mindful of the 10 minutes guidance. I see them as symbiotic. I see them as almost two sides of the same coin. So within what's called the NHS long-term plan, it was published in 2019, and it has a range of commitments and ambitions for the NHS to pursue over a 10-year period. One of those was around sustainability. One of those was around adopting what's called this anchor institution approach. So very quickly, as an overview, that's a term that's applied to institutions, for want of a better word, that tend to be very rooted in their community. So county councils, for example, would come into scope of that. Local universities, local NHS trusts. The kind of colloquial term is often kind of meds and eds, as in medical institutions and educational institutions. But it's essentially an umbrella term to describe any institution that is, as I say, is rooted in a community, tends to employ people from within that community as well as provide services to that community, and would also then procure goods and services from that community. So if you look across the NHS organisations in Staffordshire and Stoke-on-Trent, we employ tens of thousands of people. The vast majority of those live within the boundaries of Staffordshire and Stoke-on-Trent. So people are not just our service users, our patients, they're also our citizens, there are colleagues, there are employees. Many of them are also local business owners. So there is more we can do in procuring goods and services from local companies, which would in turn, from a sustainability perspective, reduce things like road miles for construction or food miles for the provision of food and nutrition within some of our establishments. So we're exploring how we might bring those two programmes together in a bit more of a formal way. As I say, I think they're symbiotic, but I think it's fair to say we're at the early stages of exploring the anchor model. To be honest.
So basically, what you're talking about is what's normally known as the Preston model, because that was initiated in Preston quite successfully. But I wondered what progress you were making into getting buy-in across these institutions. I mean, I very much support the approach, but it's about ensuring that we get buy-in. I was quite shocked that, for instance, in Staffordshire Moorlands, that the local procurement was very, very low in terms of products and services. I think it was something like 6% or something ridiculous. And so I just wondered what you were actively doing to get buy-in from a lot of organisations which, to be honest, are really not focusing on that particular local procurement model.
So I think, as I say, within the procurement guidelines as of a couple of weeks ago, all suppliers now need to have a 10% social weighting value, and that will bring to the fore some issues for local suppliers who are able to demonstrate how they can better meet the aims and objectives of NHS organisations, perhaps more so than previous procurement regimes. There is also a West Midlands anchor network that's being established, and we're active participants in that. As I say, the commitment to be anchored institutions is laid out in the NHS long-term plan. So each NHS organisation will need to bring forward its own plans. But as I say, I think it's early days, and we'll be able to bring a further update back to colleagues in the fullness of time if that's something that colleagues would value an update on.
So do you have a timeline for this at all, or is this just something which is fairly fluid? Because it seems to me that if you don't have some sort of target timeline, then it'll just sort of be left in the background.
So there's no national timeline for NHS organisations to adopt an anchor institution approach. Perhaps if I contrast it, say, with the opening slide around climate change, which I shared, which is very clear that there are particular targets for 2040 and 2045. We don't have that same level of clarity around targets, excuse me, for anchor, although, as I say, it is a commitment within the long-term plan, and there is now a West Midlands anchor network that's been established, although its first meeting is later this month. So there is some work to do.
Thank you. Can I suggest that following that line of questioning, we may want to come back in a future meeting to that specific point and concern that is being raised? Yeah. Jill Hood. Okay. Did I do something which changed your mind? Keith? Only if it relates to elections in local areas like Newcastle or those areas that are out for election. So you can ask questions providing they don't relate to specific elections in specific areas. So, for example, Newcastle Borough or Cannock Chase and Tamworth, I believe.
Okay, thank you, Chairman.
Do you want to?
Yes, I do, please. Thank you. Your section, Chris, case study, keep well, keep warm. It must be very disheartening for you and most of your staff to see the dire straits that many of your patients coming into hospital will be in fuel poverty, and you'll be knowing that you're sending them out to no hope of heating their homes. Therefore, there becomes a cycle where you're going to have them readmitted over and over again. Have you put any contingency plans in place, which I can't find in this report, but is there anything there that you've put into place?
So there is obviously there's the Beat the Cold case study that we've included within the pack. Other NHS organisations are exploring whether we can adopt a similar approach. There are some challenges to that in terms of some of the estate that other NHS organisations have got. I think if I take the point now, I broaden it widely to be about wider determinants. So we know that things like financial health, things like access to good transport, things like access to good quality and secure housing are all factors that present themselves in the NHS, whether that's about physical or mental health conditions, or indeed whether it's linked to sustainability. And I think that's why it's really important, I said at the start, that whilst I'm describing an NHS approach, and there is some very clear NHS guidance for individual trusts, actually in order for us to realise our ambitions, in order to get to net zero by 2040 or 2045, we will need to work with partners, including district and borough local authorities that do have some of the responsibilities around some of those areas. So I think we've got work to do. What we've published in the ICS Green Plan and colleagues will see this at the launch event in May is some reflection on the work that's already gone on, some updates on the work that's already in train, but actually also a plan for some of the more ambitious programmes of change that we'll need to bring forward, which, as I say, will absolutely need to be done in partnership with other organisations.
Thank you, Chairman.
Do you want to come back? Can I just make 2 points off the back of what you just said, Chris? First of all, we have a session on the wider determinants of health in June. Okay, we have a wider session on a date to be arranged, but certainly within the next 12 months. And second of all, I just also make the point that there are a range of other partners who do fund and support Beat the Cold in a similar way. Certainly Stafford Borough is one of those. I'm sure there are other districts and boroughs. I think Cannock does as well, but it's not an exhaustive list, but welcome that. Keith Flunder.
Thank you, Chair. And can I just say thank you to, I think it's Chris, the presenter. We've already received our presentation in the Staffordshire Moorlands on this very subject, so apologies if I repeat some of the elements that are there, but I hope I haven't, and I'm trying to concentrate on how this might affect our residents. For my first question is, how much will all this work, this resource that's now been undertaken by the NHS, looking at the ICS plan, have you got any idea and prediction as to whether or not that's going to distract from, obviously, the main NHS remains of keeping us all healthy and fit, and how much that was going to affect that particular target, and how many people are being involved with that, and what sort of budget there is? I also noticed that on the presentation, because I've had twice as long as everyone else here to have a look at it. 2040 is your target for internal. Now, looking at your pie chart, that's 90% of the reduction that you're going to have to do is first, and then the 10% in the other is in 2045. For me, it would probably be the other way around, but in relation to the second part of that, and we've already alluded to sort of what might be happening in other districts and boroughs and everything else, I'm just wondering, would these targets be more easily achieved if you also worked in partnership, not just with us, but rather than taking it all internally in yourself, would it not be easier for other bodies to maybe be paid for this and everything else like this? Because you can't really, you can't look at that 10% really internally, and I think it's going to be tough enough for you to be able to get to the 2040 targets internally yourselves. So whether or not you need to try and work or hand that piece of work over potentially, because that might also interfere with the primary care units and all the rest of it. I mean, by doing it individually everywhere across, it just seems to be incredibly complicated. I hope you understand the point I'm trying to make. It would be far easier if this was done with slightly bigger brushes at your level and national level, and then we could mop up the rest. I mean, I'm just thinking that, to me, at the moment, the plan doesn't really make complete sense, I think would be, in terms of how you're going to implement it. Thank you.
Thank you. So I think that's a fair observation. I don't think we're not. Again, I'm talking about a plan that colleagues haven't seen because of the because we're mindful of Purdah, and we've got this launch event coming up in May once we're beyond the elections. But I think once colleagues see that, they'll realise that it is a plan, and that we need to do some work then on the delivery of that plan. And as much as 2040 feels a long way away, actually some of the actions we need to take are immediate. We need to be doing work over the next 12 months in order to build the foundations for delivery by 2040 and 2045. I think in response to the question, Councillor, I think I'd make 2 points. The first is that you're absolutely right. The NHS will not deliver this plan by working in isolation. So we have already started to build relationships with local organisations, including local authority colleagues and universities and voluntary sector organisations, and we'll want to harness and optimise the arrangements across those organisations, so that if it makes more sense for one particular organisation to take the lead in one particular aspect, then we're able to do that, and they can either then break the new ground for the NHS to be the fast follower, or perhaps sometimes vice versa. Each of the NHS organisations, and I think I'm right in saying the local authority as well, but I will stand to be corrected, but I think I'm right in saying that, do already have dedicated officers who are supporting the sustainability agenda. Predominantly from an estates and facilities perspective, certainly in the NHS. So we do have resource that we can already draw on. Part of how we make more impact is that over time we need to become more than the sum of our parts. So how do we take those individual officers or those teams working in these organisations and build the network so that what's happening in one organisation can benefit the work that's happening in another, and expedite the progress that we need to make? Equally, there are some areas that are very specific to the NHS. So the use of anaesthetic gas in surgery is a matter for the NHS to resolve. How we move gas around our estate, from plant rooms to theatres, making sure that we don't have any leakage or so on through those mechanisms, is again a matter for us to resolve. And then there are also areas where we need to work much broadly with our communities for things like electric vehicle charging points. So we know that there is a limit on the progress we'll make around that in the here and now, because there is a limit to the number of people who've got a private driveway, for instance. So the public infrastructure around EV charging points needs to be more expansive than it is at the moment. So So I think the point about delivery in general is about our ability to work in partnership, because no one organisation will be able to do it all on their own. The point around funding is also a very good one. Again, similar to anchor institutions, I think there's a degree of symbiosis here, that it actually, in bringing forward a range of measures around sustainability, it also has a beneficial impact on quality of service and the cost of providing that service. We also know through the group that I described earlier, the NHS Greener group, that we're able to keep a very vigilant watch on any national funding routes that become available, and often when we have new NHS targets, it is accompanied by new national funding routes that we're able to tap into, and again be able to expedite progress. So that's just a few of the measures. Hopefully that's helpful.
Thank you very much. Just a quick follow-up one. Of course, we've got a work stream that we're going to be dealing with in time. I'm not going to say where it is because Purdo and everything else, but basically it's to look at local services in local places, in local towns and things like that. I hope that this will be part of that work, because I think then local services for local residents then makes more sense. And that might be the case across the whole thing. I know we're going to hear about the CAN and CAMIO and everything else. We've got to be careful what we say. But basically, the better the services are, the more local they are, the less of a carbon footprint might well be as a result of that, plus a better, more deliverable service. So I'm really hopeful that this piece of work will be part of the whole process. Thank you, Chair. And if we can have that coming back through the work stream and everything else, I'll appreciate it. Thank you.
I think that was a plea, Chris, so I'm not sure it was a question. Did you want to say anything on that?
No, I took it as a statement, Chair.
Thank you. Julie Cooper.
Am I, because I'm in Purdo at the moment, am I allowed to speak?
You're allowed to speak, but just keep very general questions and not specific about any one geography, please.
Okay, right.
If I think you're in danger, if we think you're in danger, we will just note the question.
It's nothing to do with Newcastle, put it that way. It's two questions. Partly, one is how strapped the NHS are for funding, and you're going to go all through this. So how are we going to do that? Or how are you going to do that? And the second part is, will Stoke Hospital be having solar panels? Thank you.
So if I can take those in reverse order, if that's okay. So the answer to the second question is that Stoke Hospital already does have solar panels. So the case study of Keep Well, Keep Warm, Beat the Cold, the photograph that's in that case study is from the rooftop of Royal Stoke. And they've also got them on the county hospital site. So the two main hospital sites for UHN both already have solar panels in place. I think the question around funding, I think probably plays to the answer I gave to the councillor a moment ago around our ability to tap into national funding routes, to be able to expedite progress, to be able to work in partnership so that we can take advantage of learning from experience and sharing best practice across organisations. And as I say, each NHS trust certainly, and I'm pretty confident local authorities as well, but certainly NHS trusts do have dedicated teams focused on sustainability and climate change already. So I think we're in a good place, but that's not to underestimate the size of the challenge that we need to undertake over the next 2 decades effectively.
Thank you very much for that answer. Thank you.
Janice.
Thank you very much, Chair. First of all, thank you very much for the report as well. I thought it was a lot of information in there as to where we're at now, so we can see the size of the issue that we're looking at, and certainly challenges elsewhere in the world remind us of how important it is that we look at the reliance that we have on certain types of sources of fuel. And so every credit, I think, in terms of where we're at now, and it's been interesting to listen to the delivery and how that is going to be developing, emphasis on the developing part on there. The case study I thought as well was particularly useful, and I can certainly think of local initiatives. I'm representing Lichfield City North as to how some of those can be delivered collectively, and I think that's the important part, certainly what I'm taking out of what you're saying today. We're already asking busy people, and certainly the magnitude faced in the NHS at the moment is one that I think we're all ever mindful of. Are we asking busy people to do even more things? And at the moment, he's sort of looking at what sort of engagement you're facing when you're looking at bringing all of those different bodies together, which I think is absolutely right, but just looking at how that engagement is happening and how it's being supported. Thank you very much.
So thank you for that. So I mean, I think we absolutely recognise that we're talking to busy people, not least off the back of the past 2 years, and the NHS has got a lot of priorities at the moment around returning to some kind of normality after the pandemic. I'm absolutely sure that is true of local authority colleagues as well. What we do know, though, I guess, is that the way in which there are some things that are for people like me to coordinate. So, you know, working with my clinical colleagues around the uses of particular gases in surgery, say, for instance. But actually, one of the biggest changes we will make and our ability to progress the agenda is by individual people making individual decisions on a daily basis. So whether that's to jump in the car for a short journey to the shops, whether it's what they're buying from the shops, whether it's how they interact with colleagues or patients or citizens and the way in which they do that. So we've got a real job of work to do in terms of building the case for change. What we do know, so there's a Health Foundation survey done a couple of years ago now. So this is particularly for people who work in the NHS, but I think by extension, we might say some of this extrapolates wider, which is it shows there is a groundswell of support for people in the NHS agreeing that climate change is a global emergency and that it does have an impact on health. And about 50% of those people surveyed also agreed that threat to health was right now. And I talked earlier about 9 of the 10 hottest years on record being in the past decade. So I think the groundswell of opinion is there. Where we know we need to do some work then is that not everybody understands the role the NHS has in contributing to that carbon load. So I think on the first slide we talked about 4 or 5% of the country's carbon load comes from the NHS. That's equivalent to a country the size of Denmark. So it is a significant challenge that we need to address, and being able to bring people with us on that journey and secure buy-in from colleagues will be absolutely essential. Because, as I say, there is absolutely work that individuals like me and my colleagues can do individually and together, but the biggest single change will come from the individual decisions that individual folk make on a daily basis.
Janice.
Just say thank you very much for the comprehensive answer. I look forward to the future reports that we receive on this. Thank you.
Can I just ask a follow-up from the chair then? Has there been any survey work done to sense check in Staffordshire itself what the appetite for this agenda is? I.e., do you know where you're starting from with a reality check? Or not, because, you know, one of the things about the NHS is it's not one body. You know, it goes across multiple touch points and multiple locations. So do you have that sort of granular view for Staffordshire?
So yes and no, I think, is the honest answer, Chair. So yes, in the sense that we understand the carbon load of each NHS organisation. So we understand our baseline, we understand our start point. Each NHS organisation, and this may also be true in local authorities, but I'm not cited, so apologies, but certainly within the NHS organisations, we have a range of what are called sustainability champions, effectively, which are people who have come forward on a volunteer basis to express their desire and their intent to get involved in helping us as organisations understand how we deliver change on the ward, in a clinic, or in the kind of setting that they're based in. What we don't know is what the kind of population more generally of Staffordshire and Stoke-on-Trent feel about climate change, and that's work that we'll want to do over the next year or so once we've launched our green plan. As I say, just holding off, being mindful of PERDA at that, but when we launch that later this year, one of the things we'll want to do is tap into work that the two universities have done, Keele and Staffordshire, to be able to design a model where we can begin to understand kind of what citizens feel and their view, so that we're able to run both the health model and a citizen view side by side, working, of course, in partnerships with local authorities in that respect.
Thank you, really useful. Thank you for that. Can I just take Chair's licence and ask just a couple of other questions? First of all, I note that there is an ICS Green Plan that is going to be launched in May after PERDA, but I wonder whether there's an opportunity to invite members of this committee to your launch event, and certainly circulate a summary from the launch event so that members can be fully engaged in the next stage of the process. I'm not suggesting that we all need to be in the same building, because that wouldn't be very environmentally friendly, but maybe a virtual invite might be useful.
Yeah, it will in fact be a virtual launch, Chair. So the plan is that it'll be a webinar. There'll be a couple of keynote speakers, and then we'll move into some case studies, because I think as we've shown through this conversation, really, what we need to be able to do is move beyond the kind of conceptual model of why it's important to actually what does it mean for people, what is it we're doing, and what will we need to continue to do over the next 10, 15, 20 years. And case studies are a more tangible way of connecting with communities in that regard. So it will be a webinar that's open to all colleagues across the NHS and local authorities, including elected members. Indeed, Chloe, who is on the call at the moment, is part of the communications team who's helping to design that event. So I think we've heard that loud and clear, Chair, and we'll make sure that happens within the launch event.
Thank you. If Chloe liaises with Deb Breeden, that would, who's the scrutiny officer, that would be really helpful, please. So, second question I wanted to ask, having not seen the report, but recognising it's in PERDA, I'm assuming within the report there are targets to get to the 2040, i.e. there are deliverables between now and 2040, bearing in mind that's 18 years away, because you won't want to just do this all on the last year. So I'm assuming that within that report there is those targets to get there.
There is not, Chair, interestingly. So the NHS has published the two milestone targets, the 2040 and 2045. There are, as I said earlier, things that we need to do by particular timelines. So, for instance, I talked earlier about some of the procurement changes that are coming online in April 2022, 23, 24, which get progressively more stringent. Equally, there are new estate build requirements, as we talked earlier. What there isn't, which I think is what the question alludes to, if I've understood it correct, Chair, is that to get to net zero by 2040, we need to get to 50% by 2030, say. So we've not got that clarity, but we do have, as I say, a series of measures that are rolled out over a particular timeline that we need to adhere to. One of the things we'll also want to do is work with colleagues. So I know when I presented Staffordshire Moorlands Overview and Scrutiny Committee recently, they part of the conversation there was that the ambition within that particular local authority was to be carbon neutral by 2030. So part of our conversation over the next few months as we launch the Green Plan and build the delivery plan is understanding individual organisations' level of ambition and appetite over that time frame, so that we can begin to weave all of those things through. So again, probably a bit of a yes and no answer, I'm afraid, Chair.
But very helpful nonetheless. And again, just relating back to this report we haven't seen because it hasn't been published yet, I'm assuming within there you've got your usual quick wins, short-term objectives, comparison with what's going on elsewhere, what's been part of the national plan, what's part of the local plan, and finally, I'm assuming you've got the linked deliverables, i.e. we can't deliver this if you don't deliver that as a partnership. So best example of that would be electric vehicles. You can't persuade your staff to move to electric vehicles if there aren't recharging points.
Indeed, Chair. So, as I said earlier, the report reflects on some of the work that's already been done to date, describes some of the work that's in progress, and then outlines some areas where we need to go further, in some cases further and faster. And it also gives some thought to how some of that may be achieved, as well as what we're calling contingent interdependencies. So the ability for us to move from step B to step C is completely dependent on step B being in place. There are other areas where we can move forward in a less linear fashion, but there are absolutely some areas where we need certain things to be in place before we can progress beyond that point. So yes, those points are absolutely covered, Chair.
Chris, that's really helpful. Thank you. I've got no more people seeking to ask questions from this side, Chris. So I think that leaves me to do a couple of things. Let me just summarise where I think we're up to, which is I think the MHS very clearly are saying that there is no choice but to get to net zero, and your commitment is to do that by 2040, and that is the way of keeping 1.5 alive. You have a plan, you have some milestones, and this is part of an ongoing discussion that starts today, but will evolve as we move through the years to 2040. And I think that's probably where we've got to. So on that basis, Chris, thank you for your attendance today. Thanks for your report, and thanks for the input you've given us today. We note both the report and what's been discussed this morning.
Okay. Thank you very much, Chair. Thank you.
You're welcome to stay with us or go as you want. Otherwise, I'm going to move back on the agenda to item number 5, which is the care home update, and Dr. Richard Harling. Over to you, Richard.
Thank you, Chair. So this report provides an update following the January meeting as requested. I think the main things that have evolved over the last 3 months are, first of all, the discretionary fee review, which is outlined in the report, and secondly, care homes, their COVID controls have been relaxed a little bit, although they are still subject to restrictions on visiting, activity and admissions in the event of outbreaks. In the last week, the guidance from the government has changed. I do just need to advise you in relation to paragraph 3C Roman 1, there is no longer a requirement for staff contacts to take a PCR test. That has been replaced by a requirement for staff to take lateral flow tests in the event that they are contacts, and in addition for care homes in the event of outbreaks to test all residents and staff with both lateral flow and PCR tests. So just a little bit of a live update since the report was submitted. Otherwise, Chair, I hope it's reasonably self-explanatory and very happy to take any questions. Thank you.
So let me start with Charlotte Atkins.
Thank you, Chair. I wanted to ask about the payment of the quality premium of 3% to lower paid placements. It says in the paper that this is on the basis of an expectation that it would facilitate improvements in the quality of care where necessary. How will that quality uplift be measured, and what will happen if the quality premium if there is no quality improvement? And also, the fees that the County Council presently pay are clearly lower than self-funders. Will the government's new arrangements in terms of fair fee paid mean that the County Council's fee will, in time, be the same as self-funders, given that self-funders can come to the county to organise their care?
Thank you, Chair. So first of all, we will continue to work with all care homes to try and maintain and improve quality. We will be focusing on those care homes who are rated below regulatory standards. That means requires improvement in CQC terms. And I hope what the quality premium enables us to do is to have more robust discussions with those homes where the fees are lowest, along the lines that it is more difficult for them to use low pay as an excuse for suboptimal quality, given that the council has given them a 9.24% pay increase. But it's a combination really of support and challenge for some of these care homes, support with a whole range of challenges which are very real, including staffing and managing the ongoing consequences of the COVID pandemic, as well as challenge to make sure they are doing everything they can to improve the quality of their services. In terms of fair cost of care, so the government's policy intention is to effectively equalise the rates paid by local authorities and private individuals. For the vast majority of local authorities, that will mean that net we end up paying more, and that for most self-funding individuals, it will mean that net they are paying less. There will be some exceptions to that because the rates that we pay do vary fairly considerably. And of course, the rates that self-funders pay vary considerably as well. So some local authorities and some individuals will benefit more than others. Thank you.
Do you want to come back?
What do you estimate that will cost the County Council? And have you any expectation that the government will be funding that gap?
So we're at a fairly early stage in estimating what it will cost the County Council. These estimates are pretty difficult because they depend on trying to understand not just what we pay, but also what self-funders pay. We're also doing a bit of work to try and understand bottom up what the fair cost of care actually is. There is a tool that the government was due to release to support that. So we will use that to try and calculate what we think the cost of care should be for care homes. There is increasing concern nationally, and I think the County Council Network report is referenced in the Scrutiny report, increasing concern that the money available from government for all of the adult social care funding reforms, that's fair cost of care, the cap on care costs and the more generous capital thresholds, that the funding available from government is quite a long way short of what those reforms will actually cost. And I think local authorities are gearing up to lobby government pretty hard to make sure that the reforms are in fact properly funded and that there are not uncosted liabilities falling on ourselves.
Thank you very much, Richard.
Can I just ask a supplementary on the back of Charlotte's comments? Is there also a cost of assessments as well? Is there a right for individuals to receive an assessment they wouldn't have necessarily done previously?
Yes, that's quite correct, Chair. So with the introduction of the cap on care costs and the more generous capital thresholds, we can expect that quite large numbers of people who are at the moment are funding their own care would come to the County Council for both a Care Act assessment and a financial assessment. That will require some fairly considerable additional resources, and those resources will need to be funded.
Do we know when some of that information is likely to be available?
So the tool for calculating fair cost of care, the home care tool, is already available. The care home tool is expected beginning of May. In terms of understanding the numbers of individuals who might come forward, we really have to estimate it based on the number of self-funders who we think are currently in the county, and then some sensitivity analysis on the proportions of those who might come forward and when. So we're looking at extrapolating essentially a range of resource requirements and funding requirements. Difficult to get a very precise estimate.
Really useful discussion. Thank you. Julie Butler.
Very quickly, could you please tell me, I don't know if you know the answer to this yet, but how many of the care homes have signed up for their second booster? If anybody can answer that, because, you know, it's basically aimed at them, at their age group. So any ideas how many have signed up for the second booster? Thank you.
Thanks, Chair. I think there's a figure in the report of care home staff, around about 55% have had a booster. I don't think there's a corresponding figure for care home residents. What I can perhaps do is just check the latest data point and circulate it to the committee after the meeting.
Thank you. Appreciate that. Keith Flunder.
Thank you, Chair. Just two very quick questions. I noticed that in the report there was some £32 million that have been brought forward to help throughout the pandemic within care home and everything else. My first question really is, did that cover all the costs as far as the county council and the care homes are concerned, or were there other costs in addition to that weren't covered by the grants? And my second one is slightly concerned about the occupancy rate of 80.2%, which is in the report. Does this mean that the care homes and the county council are now working far harder to try and increase that occupancy with all the variations that we've just been hearing about in terms of quality care and all the rest of it? Is that going to cause even more problems, or is that going to assist in trying to get that occupancy rate back up and therefore the care home sector to be more financially viable? I think the two are fairly linked, but one's for the county council, one's for the care homes. If you can answer those two, it would be appreciated. Thank you.
Thank you. Yes, so I'm reasonably confident that that funding from the government met most of the additional costs of COVID in most care homes. It's very difficult to give a judgment that it met all of the costs in all of the care homes, but I think broadly it did help to fund the additional activity required during the pandemic. The risk, of course, is that the pandemic, particularly as care homes are concerned, is very much not over, but that funding is non-recurrent. So the risk is that we have unfunded liabilities going forwards. In terms of the occupancy figure, so it's about 80% at the moment. That compares to a pre-pandemic figure of about 85%, which is the figure that most care homes base their business plans on. So it's about 5% adrift of what care homes would normally expect in terms of their revenue requirements. So there are, if that continues, there are two potential consequences. One is that care homes try to put up their prices further in order to increase the revenue per bed whilst having fewer beds occupied. I guess the other one is that if prices remain the same, then we might start to see some care homes struggle to remain financially sustainable. So that would be a risk to us.
Keith.
Yeah, and I just wondered if there was anything that the county council can do with its own policies to be able to support some of and increase that occupancy rate so that it becomes more of a stable marketplace for all of us who are going to be getting there sooner rather than later in some cases. But if you can let me know whether or not that's going to be sort of a target or some sort of idea about what the county council can do, if it can do anything. Thanks.
So I think that there isn't a target care home occupancy. If anything, the aspiration is to have fewer people in care homes and to look after as many people as possible in their own homes. I think the best support we can provide to the market is to give the market an indication of what demand looks like in the future. So how many care home placements we would expect to be making and how many others we would expect self-funders to be wanting. And that enables care homes to plan the sort of capacity that they're going to be putting in place for the next 10 to 20 years to try and make sure that bed occupancy is at a level that is sustainable. So I think it's that information to help their forward strategic planning, which is probably the most helpful thing we can do.
Thank you, Richard. Jill Hood.
Thank you, Chairman. I'm very pleased to read that this council is promoting innovation, but it saddens me to see that Oxyvision is being used, which I understand is fully compliant within the law, but to my mind, morally, it's not compliant. Surely if we could get the care homes to put forward more attractive packages, they'd attract more staff, and therefore our residents in the care homes wouldn't be spending long amounts of time on their own, as has been fed back to me, and they're virtually under surveillance. Just everything about this seems to be wrong, and it saddens me. I'm sorry that this council supports Oxyvision.
Thank you, Chair. So first of all, we are very keen to encourage innovation in the care home sector. There are all sorts of technologies coming onto the market that I think we could benefit from. The Rita technology, I think, is probably pretty established, and we're at a rollout stage. Oxyvision, we're piloting at the moment. The main way we see that being used is as an alternative to very close one-to-one supervision for some residents. Now, there are two benefits of that. The first one is that it frees up staff time, but probably the more important one is that this would be for people who do require surveillance. Having someone sit in person with you in a room physically monitoring you the whole time is actually very intrusive. And I think a lot of people would actually benefit from having a bit more space and monitoring more remotely and more subtly because it gives them that much more freedom. So we will pilot it. We'll have a look at the benefits, both in terms of productivity, but also the experience and quality of life of residents. And then we'll make a decision about whether or not this is something we want to support on a wider basis.
Do you want to come back, Jill?
Yes, please. Thank you for that. No surprise that I disagree with you. The very nature of the word care conjures up eye-to-eye contact, a smile, an arm on the shoulder. I wasn't suggesting for a minute that any member of staff should have to sit for hours with a person in a care home, but I think the personal touch would and is expected by people who have put their loved ones into care homes. And I will say once again, I certainly don't think that Oxyvision is the way to go. Thank you, Chairman.
Is there anything you want to say to that, Richard?
Yes, and I would agree that we absolutely wouldn't want this to be replacing that sort of personal care. I mean, I see this as a potential to complement the care that staff can provide. As I say, this is something we're piloting at the moment. We'll be evaluating it, and then we'll make a decision about whether it's something we want to roll out further and support. But again, with all of these technologies, you really have got to try them out to try and explore some of the benefits and understand some of the potential risks, because there are lots of systems coming online, and I think we would want our residents to be able to benefit from them if they are the right systems.
Thank you for that partial reassurance, Richard. Anne Edgeler.
Thank you, Chairman, and thank you, Richard, for your report this morning. But my question really is, do we have a listing of the care homes in Staffordshire, how the CQC rate them as good or outstanding? It would be quite interesting to know that. Thank you.
Yes, we do, and that information is also available on the CQC website. So you can either look at it at a list or you can search by individual home.
Anything you want to come back on?
No, thank you, Chairman.
Okay, on that basis, I've not got any other indications from this side, Richard, but I do want to just ask a couple of questions, if I can, please. Way back in December, we talked about the system pressures. We talked about, the weights being experienced to offload patients from ambulances and the impact across the whole of the system through those delays. And I would just be interested to hear where we are specifically on that discharge element, because obviously one of the key components is delays to or medically fit patients who are able to be discharged but have nowhere to go. Is that still a specific issue within your vision within specifically care homes, or is that principally an issue within home care?
So first of all, I think those system pressures are ongoing and probably at least as difficult now as they were in December. There are all sorts of reasons for those. First of all, a very high number of admissions. Secondly, quite high levels of staff sickness absence in the NHS. And then the problem of discharges does contribute as well. For us, home care is more of a problem than care homes. The specific problem with care homes is their ability to take admissions of either returning or new residents in the event of COVID outbreaks. COVID outbreaks are pretty common at the moment. We have something like 50 care homes affected right now. The government guidance has been relaxed, so it is more permissive now in terms of what care homes are allowed to do during an outbreak, including taking admissions. Nevertheless, some care homes do remain quite anxious, and I think that goes back to the very difficult time they experienced in the early days of the pandemic, when they took residents and they saw quite large outbreaks and sadly quite a lot of deaths. So what we are doing is working with care homes when they have outbreaks to try and encourage them to strike the right balance between infection control, but also timely admission, both for the benefit of new and returning residents, but also to try and allow flow through the urgent care system. It is a delicate balance. Each case needs to be handled on its merits, and we are doing our best to help care homes balance those risks and make the appropriate decisions. Thank you.
Thank you, Richard, and obviously we appreciate as a committee the work that you and your team are doing with care homes to strike that appropriate balance as well, so thank you for that. Just moving on to a second area, it strikes me that the other main user of care homes is the NHS. How much work is going into joint procurement, and just picking up the question that was asked earlier, joint planning and forecasting for that wider market?
So we do a lot of work with the NHS on quality improvement. We have joint teams, joint monitoring, joint quality improvement schedules. We do some work with the NHS on joint planning in terms of forecasting future capacity. We do relatively little at the moment in terms of joint procurement, and it may be that's an area that we want to develop in the future.
Is there a reason for that latter point? I mean, the other points I think we welcome, but is there a reason why there isn't much work done jointly with the NHS on procurement currently?
I think it's just the way that we've had separate systems that have evolved historically. So the County Council commissions and contracts for our placements. For the NHS, the commissioning and contracting is done by the North Midlands Commissioning Support Unit, who work on behalf of the clinical commissioning groups. And I guess it's just a lack of opportunity thus far to think about how we do the detailed joining up of those two systems.
And do you think there is a benefit?
Yes, there may be, and especially with the new government policy on fair cost of care. I think the opportunity is to think also about how that might apply to NHS placements and NHS funded people, as well as to local authority and self-funders.
And just a final question on this element. Is your view that the way to move this forward is through the ICS, with the establishment in July of the ICS?
So I think it would be a conversation between the County Council and the new Integrated Care Board, which is the statutory NHS organisation which will have responsibility for commissioning care home placements where they're required by the NHS.
Thank you. Really useful and insightful as ever. Final area I want to go on to, and just was seeing if anyone else wants to come in on any of these areas, is I don't get a sense of the residents' voice from the papers. I would just be interested to understand how our residents in care homes currently, or in that sector, what their views are.
Yeah, it's an interesting reflection. So good care homes will be listening to feedback from their residents all of the time. And in addition to that, where we place individuals, we do a review at least annually, just to check that people are okay from a quality of life and safety perspective. What we could perhaps do better is to find a way to collate that information strategically, so it exists at individual resident and individual care home level, but it's more difficult for us to convey that information at the level of the county council. So that's possibly something that we will look to explore over the next year or so.
Thank you. I would welcome that, and do take your point, which is this isn't about trying to point any fingers at any individual care home, and I'm sure they are working hard in the best interest of their residents, but it gives us an assurance that we don't currently have, and a visibility that we don't currently have, albeit we might only want it, maybe once a year or something, just so that we know how we're progressing. Can I just move to Anne Edgeley, who wants to ask a supplementary?
Thank you, Chairman. Following on from your questions, it's just raised something in my mind about care homes. I mean, sitting on planning and that, we seem to be, a lot of care homes seem to be wanting to be built. Would you say, Richard, that we haven't got enough care homes in Staffordshire to be able to cope with the capacity of the people that we've got to look at, that need looking after? Or do you feel that we need to progress and build more care homes? Thank you.
Yes, thank you. So if you remember back prior to the COVID pandemic, we were reaching the conclusion that there was insufficient capacity, particularly in nursing homes. And we were quite a long way down the line of thinking about the county council building 2 new nursing homes, which would have been probably towards the south and middle of the county. Then we had the COVID pandemic, and we had bed occupancy fall quite a lot, and it still hasn't recovered, hence the earlier question about bed occupancy about 80%. It is much less clear now that the county council would need to be actively supporting the development of additional capacity. We are going to review the capacity requirements over the next few months. I think that we are still in a post-pandemic phase where it is a little bit difficult to extrapolate future demand with any certainty. And of course, if we were going to commit many millions of pounds to building care homes, we would want to be very sure that the demand was there before we did that. So I think we will take a bit of time just to look at how demand plays out in the wake of the pandemic, and whether or not there is a need for the county council to intervene in the market and build new care home capacity.
Thank you for that.
Richard, just before I bring in Keith Flunder, just going back to the residents' voice, rather than creating something from scratch, it does strike me that many housing associations do quite a lot in terms of picking up the tenant voice, and increasingly that's something that is important in terms of the charter between tenants and their social housing providers, and that may be a template that you might just want to pick up and use. Keith Flunder.
Yeah, it was only really to back up your comment on getting some feedback, not just from the residents. I suggest the families would something else that we need to find out about their access. I know it's during COVID it's been really difficult, but also how the families feel about the services that they're effectively paying for as a family. I was going to also come back on I forget now, but anyway, it was to do with let me have a think. No, completely just gone. As soon as I asked that one question, I'll leave that as it is now. Sorry, sir. Sorry, Chair.
So I think that brings us to a natural conclusion, Richard. I just want to thank you for the report, because there are a number of strategic issues that you highlight. and maybe these will be strands that we want to pick up next year in more detail. Some of those strands include the quality of the care homes based on their CQC, the sustainability you touched on, fee payment we've talked about, cost-saving measures, and obviously the very important point about staff recruitment and retention. And we may just want to pick up, very much separately next year some of those strands so that we can delve in a bit more detail without being in the general areas. But otherwise, thank you for your report. We obviously note the report and the challenges that are there, and thank you and the care homes for everything that they're doing in what remains difficult circumstances. I think on that basis, we will move on to the next agenda item, if you're happy with that, Richard.
Yes, thank you very much, Chair.
So you're welcome to stay, Richard, or you're okay if you want to go. I'm going to move on to agenda item number 7, which is the review of sexual harassment in schools. And Anne, you were seconded, volunteered to do some joint work with other scrutiny committees on this point. Do you want to pick up the baton?
Thank you very much, Chairman. Thank you, Chairman, for giving me the opportunity to present this report to the committee regarding sexual harassment in schools. This report was born out of everyone's invited concerns, June 2020, when testimonies of victims of rape and sexual violence was posted online for all to see. The government's response: they commissioned a rapid review from Ofsted. The Ofsted report was published in June 2021. Findings: all schools should assume that it is happening in their school and take appropriate steps. Mostly girls, but not always. Abuse happens online. Limited impact so far of sex and relationship education. In response to the public concern and the Ofsted report, 2 members of the Overview and Scrutiny Committee, myself and Councillor Kath Perry, along with Reverend Michael Metcalfe, were asked to set up the Spotlight Review to engage with the issues and to see how well schools and agencies were responding. Please give me the opportunity to also mention now the excellent work that Helen Phillips, the lead officer of this report, has put in, and also Reverend Michael Metcalfe. A major consultation took place on January the 14th this year with Staffordshire County Council officers, school representatives, safeguarding, family agencies, police, promoting a fuller discussion and mutual awareness, affirming the responses already being carried out to engage with the issue. Everyone invited, which I mentioned earlier, was misleading and unfair. Schools could not reply or defend themselves. I must emphasise there are no schools named in this report, but we have to understand and assume it may be happening in their schools. Safeguarding policies and guidance are required to be taken into account. This report contains a substantial range of recommendations, and it gives the County Council the opportunity to be at the forefront of actions in safeguarding our children from peer-on-peer sexual abuse. May I ask the committee to thank the work group and the officers who participated, that the committee receive and note the report, noting any additional comments made at the meeting, that the committee endorse the recommendations to be presented to the Cabinet members for consideration and request to be notified of the Cabinet's response. Please be aware of the monitoring of the implementations of the recommendations will be carried out by the Safeguarding and Overview Committee. Thank you, Chairman.
Thank you for that preface, and thank you equally for the report and the work that you've done on that. A detailed report from what I could see and covers a wide area. I'm just going to be very careful that we don't treat it as a scrutiny session and that it is a feedback session. And there is a subtle difference. So does anyone, Janice, you've indicated.
Thank you, Chair. Yeah. taking that point completely there. Having had a background in the education environment and still doing some respects as well, I think that the power in which having the dialogue and sharing the best practices amongst different schools in a smaller format is probably the most effective way, and certainly not one to be underestimated. Another point that I'd like to make is about how we can have that inclusivity, so that the potential for people to maybe abstain or not participate in some of those things, when you look at the parents or the carers for some of the individuals, that there is some information that is available to do with how much there is inclusivity within any of the programmes. And then the last part that I would like to make a comment on, a lot of the times when we have issues that need to have people make disclosures, is looking at who can they turn to be able to do those, who's those people in a position of trust. And one of the concerning things that I'm hearing locally, which is influenced nationally, is about the trust of police by young women in particular. And I think that that may also be something that should be recognised as to how that is having an impact on the age of people who want to make disclosures and having that ability to be able to have that confidence and that trust. Just comments, thank you.
And do you want to come back and just acknowledge or comment on any of those, or just take them away? And
I think, thank you for that, Janice, and it's quite interesting to hear about young women with the police and everything. And I think we've got Helen sitting in the meeting, and she's probably taking notes of that to take back. So thank you for that.
I could certainly associate with your comments about young women. Absolutely. And I think some of the stuff that we see through the press, I think is a real demonstration that it is a very live issue and isn't fully recognised. Julie Cooper.
Chair, I'd just like to ask if it's possible that a copy of the report can be sent to every councillor, well, everyone in this particular, in the county. Anne's report, what she's come back with, because it affects everyone. You know, I'd just like to know if it can go to everyone. Thank you very much. Thank you, Anne.
Can I suggest it's the finalised report rather than just the report as it... I think the finalised report is the better one because any comments from today and the other scrutiny committees will be taken into account into the finalised report. So I take your general point, and I think it's a good one. And not for me to say that, but you know, but you take it'd be better they get the final report rather than the interim. Okay, Charlotte.
Yeah, just a comment really about mental health services accessible to schools, because I think over the years we found that the demand for mental health services from schools has seen huge waiting lists, you know, whether it be you know, for any service. And in the past, some schools, in fact some schools still have them, multi-agency centres where young people could go and could link up with a trusted adult or a service provider. And a lot of these MACs, these multi-agency centres, no longer exist. And they were really helpful in the past for people who were troubled. But it worries me that that we've had a number of initiatives on mental health in schools, but it doesn't seem to yet meet the demand that's out there. We've seen during the pandemic that the growth in demand for mental health services, particularly among young people, has massively increased. And I would like to get the impression about, you know, whether you think that schools are finding that they have long waiting lists for that sort of service, or whether it's improving.
Thank you very much for that, Charlotte, and I totally agree with what you're saying. Is, you know, I mean, the ambition, and it would love to see that the 400 and, is it 56, I can't remember the exact number, 400 and something plus schools that we've got in the county, that every school should have a quiet room where if a child comes to school with whatever reasons, you know, be taken into that room and helped along by, so it might be an assistant teacher, you know, that's got the capability to be able to help that child through their concerns and everything. And it would be really good that this county council took that on board in every school, you know, and this is something actually on a personal issue. I was in Westminster last week and I was talking with the prison minister, but in that discussion I actually raised about mental health and children and early intervention, because to me that is the answer to a lot of problems with children with mental health problems. So I take on board, Charlotte, what you were saying, and it is really important that we try to work towards that. But I also want to mention having a meeting with mental health, with the Chris Stanley and Jan Cartman-Frost last week. They're talking about having a Staffordshire Mental Health Day. Now that date's not been fixed yet, but I think it's probably something that we all need to get involved in, that's something for the next few months probably to be talked about. But I take on board, and I would love to see that in every school that we've got a quiet room where children can go and be helped.
Thank you. I don't want to wander off the topic that we're on, which is sexual harassment in schools, and I'm going to bring in Keith Flunder before I'm told off.
Thank you, Chair, and hopefully I don't get brain freeze this time. Thank you, Anne. Fantastic piece of work. I think it's something that we'll all agree in supporting. I've certainly worked with you alongside for some years now, looking at this. I think there's some parallels in what's going on here within the corporate parenting panel as well in terms of the Voice project. I noticed that was mentioned in here, so I assume that's where you're getting that from, to get the voice of the children in on that. And I know that Philip and others in the chamber here today have also visited schools, and I have future school visits which I'll be reporting back to this panel from in terms of that. So I'll certainly take some of these observations forward and see if I can feed back some useful more information to you, and that's with myself and Jonathan Price as well, so that should be really good. So in terms of what we need to do now, I'm not too sure. Do we need to do anything else at the moment? Or just
I don't think I want to move
comments?
into recommendations yet. I just want to discuss the report, then we'll move into the recommendations, please.
Okay, I'll leave it at those two comments at the moment, but hopefully, Anne, I'll hopefully have a chat with you before I go on the visit, so that would be great to have some feedback from you. Thank you.
Is there anything you want to come back on that, Anne? Okay, thank you. Can I'm not seeing anyone else indicating, can I just make three very small comments? I think the report is comprehensive, as I mentioned earlier. But it raised a couple of questions in my mind, particularly the first one was on page 45. And I wondered, and it picks up Janice's point somewhat, whether there is a role for peer mentors and for peer role models. Because actually sometimes individually in groups we need to call out behaviour, or young people need to call out other people's behaviour. And I wondered whether there was a role there that you might want to look at. Secondly, on the same page, I wondered whether there was an early warning system whereby rather than waiting till someone's complained, you try and pick up the behaviours that lead to someone feeling harassed and you know, maybe on the edge. And the question I had in my mind was, were the things like school absences, were the things like disruptive behaviour in class, were the things like changes in performance in school that were early warning signals that could pick up some of those behaviours that others, you know, in schools could use. The second point I wanted to pick up was about, and it's on page 51, the role of governors. And as a governor myself, I wouldn't want to suggest that, you know, the governors have to be responsible for everything, because frankly it's an expansive area that they're already responsible for. But I do think there is a role for, you know, an increased role for governors to make sure that they are assured themselves in their own schools and colleges that this is taken very seriously as an agenda. The third point I just wanted to make was it's a great report, but have you circulated this report to the schools in draft format to see what their feeling and thoughts are, and to other partner agencies? Because I think that, you know, there may be other areas that they want to build on from here, or alternatively may want to wholeheartedly endorse. Thank you.
Can I bring Helen in on this? I mean, I think she's probably got the answers to that question. I do believe it has been circulated. But again, we've got to remember it's got to go to Safeguarding Overview Committee as well to the examiner.
Yeah.
Helen.
Thank you, Chair. Yes, so it has already been circulated to everyone who participated. Obviously, it's a bit of a laborious one, this, because there are so many different scrutiny committees involved. So it has gone to everybody who participated as a draft, asking them not to circulate it further until it's been to each of the scrutiny committees, because clearly you all have an opportunity to comment on that first. Once each of those committees have made their comments, so it's yourselves today, it's going to Prosperous on Thursday, and Safeguarding will be next week, then and obviously it's a public document anyway, but at the end of that process, I will combine the comments that each of the scrutiny committees have made. Then what happens is those will be put together, and assuming each of the scrutiny committee endorses it to go through to the cabinet members, it will go to Cabinet for their response. Now, obviously, amongst the recommendations, there's a couple that are specific to scrutiny rather than the Cabinet member, so they're up to yourselves to agree or otherwise, and that is specifically that a suggestion that as the Stafford Safeguarding Children's Board annual report is scrutinised by the Safeguarding Scrutiny Committee each year, that a representative from yourselves and from Prosperous attend or are invited to attend that particular meeting, so that they can join in that scrutiny, bearing in mind the work that's happened here. And then also there are a number of things that need that progress of needs scrutinising. I noticed that the suggestion is this morning that Safeguarding take the lead on that, and that is something that we can put to the Safeguarding Scrutiny Committee. Or the alternative is that you perhaps ask the three representatives to get together again in 12 months' time to look at that in comparison to the work they'd already done, and then feedback. But that's a decision for yourselves. Can I just mention very briefly, I know Mrs. Edgeler kindly mentioned the sort of initiative originally for the government's work, and then this is the Everyone's Invited platform, which was, you know, a fantastic awareness raising initiative. I think the thing that was that certainly the people we spoke to felt was a little bit difficult was the fact that schools were named and there was no right to reply. So you know, the website itself, you know, was fantastic to raise awareness and to give people that opportunity to put forward their concerns, but I think there was a concern that schools were named and there was no right to reply. Schools aren't named now, I understand, on that site, so that has changed anyway. Thank you.
Thank you, Helen. So I think we move now to where Keith was, which is to look at the individual recommendations. I'm sure you're after another job. And so I think we should probably let's go through the individual recommendations, but I just want to preface the recommendations with one thought, that if under the model the county council runs, something is cross-cutting across multiple committees, that gets picked up by the corporate review, or what used to be corporate overview and scrutiny. And I think that we just probably need to bear that in mind when we get through the recommendations later on. We can take the recommendations one by one, or alternatively we could take the recommendations based on any concerns that people have and want to raise or pick up. Let's do them with the ones that people want to raise and pick up. So, given that no one else is putting their hands up, I just want to pick up the last two. And I wonder, and this isn't about endorsing the report, because I would hope that we felt able well, we can talk about that later on, but to endorse the report. This is about the ongoing work, and it links into my previous comment, which is if we are sending representatives to a cross-cutting issue, it should be picked up by corporate, not by an amalgam of various different committees. And there is a real danger, I think, if we're not careful, the discussion, there is a real danger that there is no accountability to the relevant committee for the discussion. And you've got to ask yourself the question whether there are any specific health-related recommendations or whether they are recommendations for education and for cabinet and for safeguarding. If your conclusion is that they all relate to safeguarding schools and cabinet, then that's not cross-cutting. I'm happy for everyone to completely disagree with me, and I'll throw the floor open. Janice, thank you.
You're very welcome. I would have to agree. I think if we're looking at something that is going to have a positive impact and is going to be quantifiable, then you're easy to do that if you've got one person or organisation group that is going to be able to say, okay, well, this is what the intentions were. Have we actually achieved it? So on that basis, I think that it is right and proper that it sits full on with one committee that has that ability then to be able to evidence what the outcomes are. That is not to say I don't think that there should be a link into that particular process as suggested, but I do think it is ultimately the book stops at one place, because it's very easy otherwise to say, well, actually, I thought you were doing this, and it gets a little bit complicated. So I would actually agree with that one.
Keith.
Am I correct in thinking that at the moment the 3 representatives are from the 3 committees at the moment that are on there? Because I know, and the other thing is I'm from Prosperous, you see, so I'm on both committees, 2 of the 3 at the moment. I do think there is an element here of health, which is to do with mental health, which is something that we've always passed the buck on in past, in respect, and it's something that for the last 4 years we have been looking more and more at, and Anne's aware of that, and supporting children within various environments, and the one area is schools. Now, that, at the moment, that comes under Prosperous. That's not something that necessarily comes under the Health Committee, but there is a health element within it. Likewise, I don't know whether we set up or ask corporate, because I like the idea of having one committee that's in charge of the outcomes and reviewing it, and then potentially if the review from corporate says that one of the other committees needs to look at it, then I think that's fine. But whether or not that working group should answer back to corporate and have the 3 committee representatives report back to corporate, as well as having this today and some feedback from each of the other committees, rather than just having all 3 committees all being mixed up together, or even 4 committees if you include corporate as well. So I do agree it's getting a little bit too complex in terms of looking ongoing work. So I don't know what Anne thinks on that one. So I'll leave it, because obviously Anne and the Reverend and everyone else has been working on it. So I'll bow to what they think as well. But that's just some suggestions there. Thank you, Chair.
Just let me make 2 points before Anne comes in. Thank you. The first one is, I think we've got to be very careful. The mental health affects everything, and we should not have an expansive brief or expanding brief, because the real danger is we don't do the stuff that we should be doing that is very clearly part of our remit. That's the real danger here. I'm not suggesting that there isn't a mental health element. I'm just suggesting that we just need to be careful not to use that as an argument. Second of all, maybe the recommendation is that we ask corporate to decide which committee it sits with, and it sits with one committee. Because actually corporate may say that it needs to sit with safeguarding, and I don't think it is for this committee to tell corporate, who after all is more senior, which committee it should sit on. Anne Edgeler.
Thank you, Chairman. Well, my thoughts actually on this are, all right, we're at this Health Committee, we're looking at this sexual harassment, it's now got to go to Prosperous, it's now got to go to safeguarding, and then it's got to go to Cabinet. And my view is that, we look at what each committee is saying, it goes to Cabinet, let Cabinet scrutinise it and see where they think it... No? No?
We're the scrutiny body. I'm sorry. We would be abjectly failing in our responsibility if we just pass it to another body. I mean, and equally, I'm absolutely against this quango mentality of one passes it to the next, to the next, to the next. And it's my whole point about one committee needs to own the deliverable. I absolutely endorse the report. It's not about that. It's about how does this get dealt with going forwards.
Okay, I fully accept what you're saying, Chairman, and yeah, it really should sit with one committee. So, you know, I'll leave it with corporate to decide.
Julie Cooper.
Chair, can I just agree with you there? Because you said health and harassment don't go. But if you're harassed, then you withdraw. So you then get health problems. So it is connected. You're starting off at the basic, and you can get into health. So they are connected, the two. We can't separate them. Thank you, Chair.
I note your comment. Okay, have we all had an opportunity to input? And do you want to just sort of summarise where your head is at? And then we'll take that into account in terms of what we recommend as a committee from here.
Thank you, Chairman. Well, as I say, we've looked at the report, and you know, moving forward, it's good to hear what everybody is saying about the report, and we take it forward to the other committees. And there's nothing more I can say, really, Chairman. It's there. It's in black and white. The problems we've got, and we have to move forward with it. Moving forward, I would like to think that we do meet again, the three of us, and discuss it further, be it in 6 months' time or 12 months' time, but I do think it's got to be sooner than later. Thank you, Chairman.
Thanks, Anne. Really useful. And you obviously sit on safeguarding anyway, don't you?
Sorry, Chairman. I've sat on that committee from the health. Kath Perry's sat on it from safeguarding. Reverend Michael Metcalf is a member of the public.
Prosperous, yeah. Okay. Thank you. So can I just summarise where I think we are? I didn't hear anyone say that we didn't welcome the report. I didn't hear anyone say that we didn't feel it was really useful and really timely. And as a result, that we would endorse the report as it stands and the work that's been done. And the only recommendation we would change is one of saying that we would like corporate to look at which one committee takes ownership going forwards of the recommendations as they come back. Are we in agreement with that course of action? I'm seeing quite a few nods.
Yeah,
there you go. I think we're in full agreement. And thank you for the work you've done. Really useful. And can we minute that through the minutes of your involvement and the quality of that piece of work? Thank you. Right, nearly there. District and Borough Health Scrutiny updates. Who would like to update us? Reports have been circulated. I'm getting no indications, so on that basis, I'm going to suggest we note them and move on. So let me move on to the work programme, item number 9. I think it is incumbent just to say a few words in advance of the work programme. Thanks, Helen. So the comments, and I'm going to look to Tracy Shewan just to make sure I don't stray too far off piste. The comments I just wanted to make was, since our last meeting about 6 weeks ago, there's been the further publication of the final stage of the Ockenden review, which I'm sure many will find was shocking, and in today's day and age, frankly, unbelievable. I have met with the Chief Exec Designate of the ICS to discuss Staffordshire's response And I understand that there has been a review of the recommendations versus the lie of the land in Staffordshire. And I have some assurance that that review is, I think, classed as a green review against a red, amber, green rating. On that basis, I don't suggest that we investigate further at this moment in time maternity services in Staffordshire. However, I do suggest what we do is we integrate those questions and the outcomes from the review as part of further work that is already ongoing on maternity services within Staffordshire. Tracy, is there anything you want to add to that or put in a better way, please?
No, the services in Staffordshire and Stoke-on-Trent will all have to be reviewed again in light of the Ockenden report. There'll be recommendations in there that we'll all have to take to make sure that we can assure ourselves that services are as such. We'll also have to look at our transformation programme, because if there's any recommendations from the Ockenden review that impacts on the plans for the future of maternity services, all those will have to be taken into account as well.
Thank you for putting that in English much better. Phil Hewitt.
Yeah, Chairman, excuse me if I'm getting this wrong, and excuse me for fundamentally disagreeing with you. I think I am. The Ockenden report was damning and frightening in every sense of the word. And when I read, beyond the Ockenden report, and other maternity services are saying that they would like the same to be looked at. I'm frantically trying to think of one recently that wrote to the writer of the Ockenden report and said, can you come and look at ours? Aren't we incumbent to look at this anyway, Chair? And I got the impression you said we're not going to do that. Am I wrong? Because I think as a scrutiny meeting, when we've looked at this, I think it would be wrong of us not to actually say, even though we think everything's A-OK, let's have a look. Did I misread your comments, Chair?
I probably wasn't clear enough. I absolutely agree with just about every word you said. The real question is when. So I think it is incumbent on us as a scrutiny committee to ensure that we have done the deep dive within Staffordshire. And the real question is when, i.e. we should have a report coming back to us on maternity services in July or September. And given that we have a review that has already happened within the NHS in Staffordshire, which indicates a green rating, I'm suggesting there is no need to call an emergency meeting tomorrow morning to go through something that we should be picking up absolutely in July or September when we look at the shape and future of services in Staffordshire at that stage. That's my suggestion.
We are now in full agreement, Chair. Thank you.
Thank you. Does anyone else have anything else on that item? Charlotte?
Just to say that the Ockenden report was hardly a surprise, given the House of Lords did a very comprehensive report into maternity services and saw that 8 out of 10 midwives reckon they didn't have a safe level of staffing within their unit. So, in fact, not a surprise at all, just fairly inevitable. And I think that one of the key issues that we have to look at is staffing levels and also skill levels, because I think the Ockenden report, the key issues that came out of that was one, of course, that you had management not listening to mothers, families, but also the whole issue of staffing and skill levels, which was absolutely crucial within that whole area. And so I think that's got to be the basic thing. I agree that we don't need to have an emergency response to it, but it's very, very clear that not only maternity services, but actually women's health in general is discriminated against in terms of priorities. Now, interestingly, the waiting list for maternity services after the pandemic has gone up 60%, and it has the highest waiting lists in terms of any medical speciality than any other speciality. So, women's health is being downgraded in terms of priority of the NHS, and so it's absolutely vital that we at the bottom of all this is the whole issue around staffing. So I think that's what we've got to be looking at, and we could probably get a fairly quick response to what the vacancy levels are within Staffordshire before we even look at the issue come July.
Thank you, Charlotte. Just 3 points out of there. You're absolutely right. The final report on Ockenden follows a previous report, so you're absolutely right. It should not be a surprise to anyone. Second of all, I think you're recommending to future committee members to do some homework, which was to read the 250 pages of Ockenden, and I think that's a good suggestion, Charlotte. I don't think we'll test people word for word, but I think the principle is exactly right. And you will be aware that on the future work programme, women's health is very much an issue, and I think that resonated across a number of members when it was originally brought up. Jill Hood.
Thank you, Chairman. Yes, I'm Jill. I remember now. Thank you, Chairman. I remember 100 years ago when I first started nursing, you would do your state-registered nursing, and then you would decide which specialist field you were going to go into, and then you would have an equally long length of training. These days, of course, that's changed. You can go straight into midwifery. Not something I agree with, but there we go. It seemed to have been working. We saw the Ockenden report, and then a few days later there were, I think, 2 hospitals who were also criticised. I think this is the tip of the iceberg, and I'm sorry, really sorry to say that. I think women now are gaining a strength through social media to come forward and give their reports of what's happened to them. And I think before long we will be holding an inquiry, and we will be part of that inquiry and part of that scrutiny. And I absolutely welcome it. Thank you, Chairman.
Thank you. So I think that probably covers the work programme as it's Angela.
Thank you, Chairman. You know, listening to what everybody's saying and about this, I mean, we're talking about lives here. We're talking about people losing lives. And I know we've got a really busy programme in front of us, but somewhere, somehow, we have got to scrutinise this really thoroughly because, as I say, people, young babies, mums are losing their lives.
Sorry, we are going to scrutinise it. I want to be absolutely clear to everyone in this chamber that there is no suggestion from the chair that we are not going to scrutinise this issue. The question is when we scrutinise this issue, and the recommendation is that we scrutinise it alongside maternity services in July or September when it comes back. Have you any other comment that you're not in support of in terms of that proposal?
No, I'm just pleased that we're going to scrutinise it.
Thank you. Can I move off the work programme as it stands? And just also need to note one point, which is slightly different to what I've just said, which is obviously it's for the new committee in May to decide what their work programme is, but my recommendation is that it is July and September alongside what I've just said. So on that basis, I'd like to close the work programme discussion and just make a further comment, which is that when the new committee is formed in May, there will be a draft work programme for the new committee to agree, and that is in line with the work programme as it currently stands, taking into account this conversation we've just had. That brings me on to the last item of the agenda, which is the next meeting. The next meeting is the 30th of May, 2022. However, given today is the last meeting of this municipal year and this committee, I would like to take the opportunity to thank members and officers for their hard work, input, observations, insight over the last 12 months. I do know that, I don't know what the makeup of the new committee will be, well, even the chairmanship, according to some people. And what it will be post-May. But I do hope that for any of you who want to remain with the committee that you will signal and be able to do so. Thank you for your hard work and insight. And on that basis, I would like to thank everyone and wish you a good afternoon. But before I do so, Phil Hewitt, you want to come in?
I think, Chair, it's worth saying, and I hope everybody agrees with me, that you are an excellent chair. And you have chaired the meeting really well, Chair. It's been a pleasure to be on this committee. It's, I guess, in the gift of the leader, where I do hope I'm sitting here next year. Yeah, and thank you personally, and I think from our committee as well. Thank you, Chair.
Nothing further to say. Thank you. Good afternoon. Meeting's closed.